Hypertension is one of the most frequently tested topic in exams. It is defined as clinic blood pressure more than 140 by 90. If any one of these values is above normal, then it is hypertension. In 90% of cases, hypertension is primary, which means that there is no identifiable cause. In 10% of the cases, hypertension is secondary to some cause. The most common secondary cause of hypertension is primary hyperaldosteronism. Other causes include peuchromocytoma, Cushing syndrome, Liddle syndrome, congenital adrenal hyperplasia, and acromegaly. Renal diseases which can cause hypertension include glomerulonephritis, pyelonephritis, adult polycystic kidney disease, renal artery stenosis. Drugs are very important to remember: NSAIDs, steroids, monoamine oxidase inhibitors, and combined oral contraceptive pills. Other causes include pregnancy and coarctation of aorta. If the first blood pressure reading is more than 140 by 90, then take a second reading in the same concentration and use lower of the two readings for management. For diagnosing hypertension, the patient will have to check their blood pressure at least 4 days and preferably 7 days. They will have to check their BP 2 times per day, then discard day 1 reading and take average of the remaining. If average is more than 135 by 85, then this patient is hypertensive. If it is less than 135 by 85, then this person does not have hypertension. In newly diagnosed hypertensive patients, you can do the following investigations to rule out secondary causes or end organ damage and to assess the cardiovascular risk. So you can do urinalysis, glucose to exclude diabetes, renal function test to exclude chronic kidney disease, serum potassium to rule out hyperaldosteronism, ECG to exclude left ventricular hypertrophy, and lipid profile to rule out atherosclerosis because it increases cardiovascular risk. The best lifestyle change that can decrease blood pressure is to lose weight. Losing weight can decrease blood pressure more effectively than other factors listed here. Dietary salt intake should be decreased to less than 6 grams per day, which is 1 teaspoon. Stop smoking, decrease alcohol consumption, regular exercise, decrease coffee intake, increase vegetable and fruits intake, and encourage relaxation. The drug of first choice depends upon the patient's age. If age is less than 55 years, the first drug that you should give is SEE inhibitors. If age is more than 55 years, then the first drug that you will give is either calcium channel blocker or a diuretic. If both options are present in the exam, you will choose calcium channel blocker because it has comparatively less side effects and it can control blood pressure more effectively as compared to diuretics. The diuretics of choice are chlorthalidone and indapamide. Hydrochlorothiazide can also be used, but chlorthalidone and indapamide are preferred. If patient is taking ACE inhibitor and blood pressure is not controlled, then ACE inhibitor should be combined with either calcium channel blocker or diuretic. And if the patient is taking calcium channel blocker or diuretic and BP is still not controlled, then it should be combined with ACE inhibitor. If blood pressure is still not controlled, the patient is taking two drugs and blood pressure is still not controlled, then all three drugs should be combined, that is ACE inhibitors, calcium channel blocker, and diuretic. And if patient is taking three drugs and blood pressure is still not controlled, then as a general practitioner, refer the patient to specialist for blood pressure control. There are some special conditions in which we will override the ACD drugs that we just discussed in the previous slide. In CKD patients, the drug of first choice is ACE inhibitors, in BPH, alpha blockers, in osteoporosis, thiazide-like diuretics, angina, and post-myocardial infarction, beta blockers. The side effect of ACE inhibitors is hyperkalemia, which can cause life-threatening cardiac arrest. Calcium channel blockers can cause ankle edema, and diuretics can cause hypokalemia, which can then cause cardiac arrhythmias. ACE inhibitors are contraindicated in pregnancy and bilateral renal artery stenosis. Calcium channel blockers are contraindicated in AV blocks. Diuretics are contraindicated in diabetes, gout, hyperlipidemia, and pregnancy. The drug of choice for hypertension in pregnancy is labetalol. If labetalol is not available, then we can give calcium channel blockers. If labetalol and calcium channel blockers are not available, then we can give methyl dopa. Hydralazine can be given in acute hypertensive cases, but it is not the drug of choice. It should be given only if IV labetalol and IV calcium channel blockers are not available. Drugs which are absolutely contraindicated include ACE inhibitors and ARBs because they can damage the fetal kidneys. Diuretics are relatively contraindicated because they decrease the blood volume, which can then cause hypoperfusion of placenta. Blood pressure targets in non-diabetics depends upon age. If age is less than 80 years, then blood pressure target is 140/90. If age is more than 80 years, then blood pressure target is 150/90. In uncomplicated diabetes, blood pressure target is 140/80, and in complicated diabetes, blood pressure target is 130/80. In hypertensive urgency, the patient will have systolic blood pressure more than 180 or diastolic blood pressure more than 120, and there will be no signs of end organ damage. In such case, if the patient is already on medications, check compliance, then restart or optimize the dose of treatment. If not already on medications, then you have two options. The better option is to start a long-acting antihypertensive that is SE inhibitor, calcium channel blocker, or a diuretic according to the guidelines that we studied earlier. Another option is to stabilize the BP through oral captopril and then give a long-acting antihypertensive. The aim for blood pressure is less than 160 by 100. However, BP should not be lowered by more than 25 to 30% over the first 2 to 4 hours because it may cause hypoperfusion of the brain, heart, or lungs or kidneys. In hypertensive emergency, the systolic blood pressure will be more than 180 or diastolic blood pressure more than 120 with signs of end organ damage. So the basic difference between hypertensive urgency and hypertensive emergency is that in hypertensive urgency, we do not have an organ damage, and in hypertensive emergency, the patient will have an organ damage. What are manifestations of an organ damage? Confusion, headache, blurred vision, encephalopathy, for example, seizures, nausea, vomiting, chest pain, shortness of breath, and papilloedema. As a general practitioner, open the IV access and refer urgently to the hospital because this is a medical emergency. A 71-year-old man is referred to the outpatient clinic for advice on his antihypertensive treatment. He has a history of stroke and long-standing uncontrolled hypertension. His blood pressure recordings at home and at his surgery within the past 2 weeks were 188 by 216 and 176 by 208. His therapy comprised ramipril, atenolol, and amlodipine. Sodium is 138, potassium 2.9, urea 8, creatinine 88. Which of the following is most likely contributing to the treatment failure? Antacids, NSAIDs, table salt, pseudoephedrine. The answer is NSAIDs. Table salt can also increase blood pressure, but not as much as NSAIDs can do. So NSAIDs is a better option here. A 70-year-old man admitted with left lower limb swelling and pain diagnosed as DVT where heparin was started. He has a history of diabetes mellitus, hypertension, and chronic heart failure. He is on insulin, furosemide, and enalapril. Blood pressure is 110 by 70. Heart rate is 76 per minute. Oxygen saturation 94%. Sodium is 135. Potassium 6. Chloride 107. Urea 7.9. Creatinine 120. APTT 50. Prothrombin 14. Which of the following medications should be discontinued at this stage? Insulin, enalapril, heparin, furosemide. The answer here is enalapril. SE inhibitors can cause hyperkalemia, as in this patient's. Potassium is quite high, so we will stop the SE inhibitors. A 36-year-old man with multiple health problems presents to the emergency department with an episode of bronchospasm. He has a history of asthma and hypertension. He is undergoing a medication review. Which of the following medications is most likely to be responsible? Salmeterol, atenolol, ramipril, or aspirin? The answer here is atenolol. Aspirin and NSAIDs can also cause bronchospasm in asthma, but beta blockers are more important. So atenolol is a better option here. A 66-year-old man comes for follow-up. He has shortness of breath on exercise, which have increased over the past few months. He became unable to walk more than 200 to 300 meters on the corridor and cannot climb the stairs easily. He has history of hypertension and currently on amlodipine 5 milligrams OD and indapamide 2.5 milligrams OD. On examination, he has bilateral basal crackles and mild pitting ankle edema. Blood pressure is 188 by 96, heart rate 79 per minute. Hemoglobin is 133, sodium 138, potassium 4.2, creatinine 133. Which of the following is the most appropriate next therapy? Spironolactone, furosemide, bisoprolol, or lisinopril? The answer here is furosemide. This is patient of heart failure and he has volume overload as indicated by shortness of breath, bilateral basal crackles, and ankle edema. So in volume overload, the drug of choice is loop diuretics such as furosemide. Although blood pressure is also quite high, but here the first aim is the primary objective is to decrease volume overload and then decrease blood pressure. So blood pressure needs to be controlled, but volume overload is the first priority. A 66-year-old man with hypertension comes to the clinic for a follow-up. He is currently taking a combination of losartan and amlodipine, which is failing to keep his blood pressure within target. Examination is unremarkable. His blood test and renal function profile were within the normal limits. What is the most appropriate next step, assuming he has no relevant contraindications? Add ramipril, add atenolol, add doxazosin, add indapamide. The answer here is add indapamide. This patient is already taking ACE inhibitors and calcium channel blockers, but his blood pressure is still not controlled. So according to guidelines, we will add ACE inhibitors. A 76-year-old male presents for routine checkup. Blood pressure is 152 by 95. First reading, what is the most appropriate next step in management? Ambulatory blood pressure monitoring, start antihypertensive medication, repeat blood pressure twice during the same clinic visit, and home blood pressure monitoring. The answer here is repeat blood pressure twice during the same clinic visit. According to NICE guidelines, when you get first reading of high BP, repeat the blood pressure during the same consultation and use the lower of the two readings to decide about further management. Thank you very much and good luck for your exams.